This video will demonstrate a temporoparietal craniotomy for resection of distal frontal sylvian arteriovenous malformation. The patient was in his early 60s. He presented with headache and seizures. His past medical history was notable for prior embolization of his brain AVM. He was neurologically intact. Here is his MR imaging studies, which demonstrate some flow voids in the distal right operculum, lateral to the insula. These flow voids can be seen on the sagittal view to the right, lying in the operculum but on the frontal side. His angiogram demonstrated this cluster of nidus sitting along the M3 branches as they turn from the M2 segment into the operculum. Notice the venous drainage that goes to Labbé inferiorly, Trollard superiorly, and sylvian veins anteriorly. This AVM had a Spetzler-Martin grade of 1 and a Lawton-Young grade of 4, giving it a supplemented Spetzler-Martin grade of 5. The patient position, skin incision, and craniotomy are all shown in these illustrations. Surgical strategy consisted of the right temporoparietal craniotomy, sylvian fissure dissection into the operculum, wide splitting of the operculum to expose the feeding arteries, skeletonization of M3 feeding arteries, AVM circumferential dissection, division of the draining vein, and unblock AVM resection. Here's an overview of the surgical exposure. The nose is to the left, the back of the head is to the right, and the top of the head is to the bottom of the screen. Here, the distal operculum is being dissected. You can see these arteries running through the operculum and adherent to the frontal and temporal lobes. These arteries are mobilized off of the peel surfaces and parted to one side or the other. Small bridging veins need to be divided to further open the operculum here. These arterial trunks are then followed deeper. They serve as a guide to show you the separation plane between the frontal and temporal sides of the operculum. Here, the small tuft of abnormal arteries is encountered. These are cauterized, and this helps to begin the definition of the nidal margins. For this case, the key will be to skeletonize the trunks running through the operculum. These M3 trunks are shown here, and they give off these small, fine branches that then curve and go into the AVM nidus. The main trunk needs to be preserved, but these little branches coming from the trunk are cauterized one by one. This is what dearterializes the nidus. You'll notice that these trunks run in the operculum, but the branches can run in all directions from the trunks. These abnormal feeders are cauterized from distal to proximal, and as the proximal portion of the artery is reached, the nidus is essentially dearterialized. Notice that that main trunk has these little stumps of feeders that remain. The key, though, is to make sure that that main trunk continues onward to supply its distal territories. Now we can begin to circumdissect the AVM. I'm getting into a little bit of brain parenchyma here to define the inferior margin of the AVM. Here is that large arterial pedicle that had been previously embolized. This defines the inferior margin, and now I'm working my way deeper around that medial plane. There still are some small feeders coming from the M3 trunk more proximally. You can see those here. These are once again cauterized and divided as part of the skeletonization. And here now the vein draining the nidus has darkened, and I can cauterize it and cut it. This now disconnects the nidus from the draining vein. The nidus can be rolled away. It can be freed of its last adhesions here and resected en bloc. Here is the specimen rolling out of the resection bed, and you can see this is a small, compact nidus, but deep within that operculum. Icy green videoangiography confirmed no further shunting in the draining veins. Here is our final overview. This case is a nice example of sylvian AVMs that require skeletonization. Skeletonization is needed when you have a transit artery, meaning an artery that goes by an AVM but continues on to a distal territory. The artery needs to be skeletonized, meaning that all of the branches coming from the trunk and feeding the AVM must be cauterized and divided. This dearterializes the nidus. The other types of arteries are shown in the upper left and include the terminal feeders, the bystander arteries and the choroidal perforating arteries. This illustration shows the frontal sylvian AVM. The illustration to the right shows how these AVMs lie in the operculum, but within the parenchyma of the frontal lobe as opposed to the temporal lobe or the insula. The fourth variation of the sylvian AVM is a pure subarachnoid AVM, which lies within the subarachnoid spaces of the cistern. This relationship to the frontal lobe is shown again in the illustration to the left. The patient tolerated the procedure well. He had no new neurological deficits. He was discharged home on postoperative day 2. His postoperative angiogram shows complete resection of the AVM, and note the nice preservation of those frontal en passage transit arteries. In conclusion, surgical resection is indicated for arteriovenous malformations in patients with favorable Spetzler-Martin and Lawton-Young grading, that is, supplemented grade less than or equal to 6. Frontal sylvian AVMs are fed by the superior trunk of the MCA, with the inferior trunk typically uninvolved. Frontal and parietal arteries and M3 trunks with en passage arteries that supply distal territories are preserved by skeletonization of the feeding artery in a distal to proximal direction of dissection. Normal bystander arteries course adjacent to sylvian AVMs and must not be mistaken for AVM feeding arteries. Thank you.